much of this meeting. Let me introduce somebody who probably needs no introduction to most of you, Eileen Moran, who has been a longtime activist in the retirees chapter and in the PSC around healthcare issues and on our safety net committee. So Eileen, why don't you introduce the speakers and get us started?
Okay, it's my pleasure. Okay, we're going to start with introducing our very wonderful Assemblyman Dick Godfrey. He's retiring at the end of this year, and he's the longest serving legislator in New York State history and chair of the Assembly Committee on Healthcare. 30 years ago, he first proposed the single payer New York Health Act. He is arguably the most tireless legislative advocate and organizer for healthcare reform and universal healthcare in New York State. So without further ado, we're going to hear from Assemblyman Dick Godfrey, and also the Q questions for Dick we're going to take immediately because, as you will know, the Assembly is still in session. So we have a precious window of a half hour with him, and then he's going to have to go back and do our business and do more advocacy for healthcare. Thank you, Assemblyman, and you have the floor.
Well, thank you very much. Good afternoon. So for those of you who may not know all that much about the New York Health Act, it's my bill to create a single payer healthcare system to cover all 20 million New Yorkers, regardless of age or employment or whether you work or not, regardless of immigration status, et cetera. It would be more thoroughly comprehensive in its coverage of benefits than any health plan I've ever heard of. I keep asking people if there's something your health plan covers that the New York Health Act doesn't cover, please let me know. So far, nobody's come forward with anything. One important point, particularly for retirees, is that it would cover long-term care. Almost none of us have insurance that covers long-term care. And when I say long-term care, that means home care or nursing home care. And that would be a covered benefit. And benefits under the New York Health Act are fully funded, no deductibles, no copays, no restricted provider network. So there's no out-of-network charges. And the funding would be through a progressively graduated tax based on ability to pay. So income in higher brackets would be taxed at a higher percentage than income in lower brackets. The first $25,000 of income would be tax exempt. And for people who are on Medicare, the first $50,000 of income would be tax exempt. And this would be a tax that would be levied on payroll income, which is any income that is subject to the Social Security FICA tax. And it would also apply to any non-payroll income like dividends and capital gains and the like, if it is currently subject to the New York State income tax. Those are the basic features of the bill. By the way, they're just for retirees, a couple of interesting points. A public sector retiree, which are the retirees whose coverage we can regulate. If you currently have retiree health coverage and you remain a New York resident, you will get New York health benefits, which will be far and away dramatically better than any coverage that you now have, whether it's Medicare or anything that supplements Medicare, et cetera. And secondly, if you move out of state, if you are currently eligible to take your public sector retiree health benefits with you out of state, you would be able to do that. So those are the basics of the bill. It has passed the Assembly in New York actually 5 times. We passed it the first year we introduced it in 1992, and it passed in 2015, 16, 17, and 18. The reason it hasn't passed since then is that once we had Democratic control of the state Senate, one particular group of opponents of the bill became very vocal. Who am I talking about? I'm not talking about the insurance industry. They've always opposed the bill. Their opposition is not what's holding it up, not in legislative bodies with a Democratic majority. The State Business Council has always opposed the bill. That's not what's holding it up in legislative bodies that have a Democratic majority, as the Assembly and Senate do. The opposition that is holding up the bill is the opposition of almost all of New York State and local public employee unions, CSEA, PEF, NYSET, UFT, et cetera. I guess PEF may actually not have a formal position either way, but CSEA, a lot of the other public sector unions, UFT, NYSET, DC 37, are all opposing the bill. Their view seems to be that they think they have terrific health coverage. And how do they know the New York Health Act will be as good as the coverage they have? And the New York City public sector employees have a contract under which the city pays the whole premium. And under the New York Health Act, it requires employers to pay at least 80% of the premium. They could pay the whole premium, presumably through collective bargaining. So the New York City unions say, gee, we already bargained for 100% of the premium being paid. Why should we have to bargain for 100% of the New York Health Act payroll tax to be paid? Now, we've offered several pieces of language to the public employee unions, guaranteeing that any benefit that's covered by any public sector health plan, state or local, would be guaranteed to be covered by the New York Health Act. We've offered language that says that if a public sector employer is now paying a certain percentage of the premium on the health plan, they would have to pay at least that percentage of the New York Health Act tax. So they'd have to pay at least 80%. And if they're now paying more than 80, they'd have to pay more than 80. And we've offered that language. We've tried to accommodate the concerns that the public sector unions have voiced. So far, it's been very frustrating because they have not responded to the language that we've put forward. So we're hoping that in the next couple of weeks, we can get some response from the public employee unions. And, while time is short before the session ends at the beginning of June, if people are committed to working something out, something can be worked out very quickly. I'm hoping we can get that done this session. If not, whoever picks up the bill after I retire will hopefully be able to work it through. Although we can continue negotiating into the summer and fall to try to set something up for next year. So that's where the bill now stands. It's largely up to the public employee unions to work with us to make a bill that meets all the principles of universal coverage and delivers the savings that come with universal coverage and the enhanced benefits for public employees like for all other New Yorkers. And maybe we can get this done.
Thank you. For questions for the Assembly member, please raise your Zoom hand so we can recognize you. If you're looking for your Zoom hand, okay. Joan Greenbaum, your question. And then I see Mike Frank and then Francine. Okay. Please unmute. Yeah.
Yeah, did. Thank you, Assemblyman. This has been a long, long struggle. And the obvious question here is, here the city of New York had a chance through its unions to back this universal coverage New York health bill and save a tremendous amount of money. Instead, they chose to kick us off or try to kick us off Medicare and put us on Medicare Disadvantage. It seems like a no-brainer, but obviously it was a brainer because the big New York City unions like DC 37 and the teachers union were opposed to this universal bill. So what do we do now? Give us some tactics that get us to fight for the bill, hopefully without stomping too heavily on our sister unions.
Well, I would say any, if PSC can support the bill, that would certainly.
We do.
Well, I don't know if Professional Staff Congress has endorsed the bill.
Bill, I'm asking Bill, the chair.
The PSC has endorsed the bill.
It has? Okay.
It has endorsed the bill and encouraged municipal labor to sit down and negotiate with you.
Okay, well.
That the MLC, has raised, some important issues, but seems to me that they're all solvable, and that's the position of the PSC.
Well, I think it's important for PSC and the retirees to reach out repeatedly to others in the public employee union world. But it would also be very valuable if both the PSC and the retirees reached out, each of you, to your own assembly member and senator, and reached out to Speaker Carl Hastie in the Assembly and Majority Leader Andrea Stewart-Cousins in the State Senate to let them know how important you think this is. And those voices, while it's late in the year, if those voices can be very effective, but it's got to be done soon.
Okay, thank you. Mike.
No.
Senator, you mentioned that you tried to accommodate the concerns of the unions who are objecting or who are not supporting this, but they have not responded. Given that, is there a deeper objection that is not being articulated by the unions?
Well, I don't know. Many labor leaders, when I talk to them, every labor leader I know, including public sector labor leaders, says that protecting the union health plan, every time they're at the bargaining table, they have to give up wages and other benefits in order to protect the union health plan. It's like the number one issue at the bargaining table. And many labor leaders say that, and then say, for crying out loud, pass the New York Health Act so we can get the health benefit off the bargaining table so we can focus on wages and benefits. For reasons, if there are reasons other than the kinds of questions that I've talked about that are on the minds of public employee union leaders, I'm at a loss to explain. And I generally try not to, analyze people. I try to take people at what they say, and the kinds of issues they've raised. How do we know what the tax will be 5 years from now? How do we know it won't go up? And my answer to that is, you don't know what the premium on your union health plan is going to be a couple of years from now. The one thing you can be almost certain of is that it's going to go up because it's gone up repeatedly in the past. And even if the city is paying the whole premium for the municipal workers, that means the city has less money to put into wages and other benefits. Or it puts pressure on the city to do things like this Medicare Advantage stunt for retirees. And, the advantage of a single payer health system is that we get dramatic savings because we save tens of billions of dollars that we now waste on insurance company overhead and administrative costs and profit. We save tens of millions on what we now pay to healthcare providers to have the administrative staff to fight with health plans. And the New York Health Act would have enough bargaining clout to bring down prescription drug prices. So, when you ask what will it cost in the future, the first answer is it's going to cost a lot less than it costs now, and the benefits will be dramatically richer, including home care and nursing home care, and who knows what that's going to cost in the future for retirees. So, it's been so far very frustrating getting a response from the public employee unions. Lately they've said, well, we're looking at it. We'll be back in touch. I plan on making a couple of phone calls later today that I hope may prod some response. But if people within the public employee union movement, including you as retirees, can speak up within the union movement and alerting your legislators as to where you stand, I think that can make a difference.
Thank you.
Francine had a question, but I don't know if she's still ready to ask it. Francine, please unmute yourself.
No, my question was answered. Thank you.
Oh, okay. Okay. Any additional questions for the Assembly member? I don't see any additionally raised hands. So thank you, Assembly Member Dick Godfrey.
Well,
Yeah.
And thank you to all of you for your support for the bill. It's terrific to know that.
Great, thank you. And now we will go on to our second speaker for today, which is Mark Dudzik, and he is the national organizer and chair of the United States Labor Party, as well as a labor activist. For 18 years prior to becoming a Labor Party chair, Dudzik was president of Local 8-149 of OCAW, a branch of the Oil, Chemical, and Atomic Workers International Union. He is also the national coordinator for the Labor Campaign for Single Payer, which advocates single payer healthcare nationally, as well as whatever state can do it first. And without further ado, I'll let you hear from Mark, but I suspect Mark might be able to enlighten us even further on what the elements within labor that are resistant, where that resistance is coming from. So take it away, Mark. Thank you.
Well, thanks, Eileen. Thanks for inviting me. Just a quick correction. I think the bio you read that from is a little bit outdated. We kind of put the Labor Party idea on the shelf in the early 2000s. But one of the ideas that we were actively working on when we were trying to explore the possibility of building an independent working class party in this country was the fight for single payer healthcare in the US. And that was a project that had huge resonance within the labor movement, even back 25 years ago. And we've kind of continued that organizing through the labor campaign for single payer. So it's great to be here. And let me just say, thank you, Dick Godfrey, as you move on to your next stage in your life. You've been on this, at least 30-year long march towards making healthcare a right for everybody in New York. And, your work is just really important, both to the people of New York and to the healthcare justice movement nationally. So you've just made amazing contributions to this. Just want to mention that I am a proud City College of New York graduate. Like many, if you were a teacher, many of your students were on the 10-year plan. I was one of them. I dropped out in 76 when, after they instituted tuition, and then went back at night and finally got my degree in 1984. But the CUNY is it's a huge resource. And, I've, like many other people, I've really think very fondly of my experiences there and what that project really meant to a lot of working class New Yorkers over the years. So we launched the labor campaign for single payer in January of 2009, right before the inauguration of President Obama. It seems like a real long time ago right now, but this was a moment of real hope in the healthcare justice movement. There was going to be a huge national debate about the future of healthcare that ultimately ended in the Affordable Care Act. And our interest was really to ensure that the grassroots voices of labor who were advocating for a single payer Medicare for all model, that those voices were heard both within the labor movement and within the national debates. So when we launched this project, we came together around three basic principles. Number one, that healthcare is a basic right, must be treated as a basic right and a public good, and that it should not be treated as a commodity or as a benefit that's linked to employment. And that under the conditions that we were looking at healthcare reform in the US, that meant that we were supporting a transformative reform that would expand and improve a system, the national Medicare system, to cover everybody from birth to death around all medically necessary procedures. And, by implication, we also support state level campaigns with the same goals and the same purposes moving forward. The second thing that brought us together is that the fight to make healthcare a right in America is not really a fight about picking the best policy proposals. It's not a fight about crafting policy and the minutia of policy. Nearly every other industrialized country in the world has figured out how to make healthcare a public good available to all of its citizens. So there's not a lot of deep policy that has to go into figuring out how to do that in this country. Everybody else has been able to figure it out. This is really rather a fight about power. The problem in the United States, the reason that healthcare is not treated as a right is because there is a gigantic industry that we call the medical industrial complex that stands between the American people and their healthcare. And this industry now composes almost 20% of the US economy. And it's, the biggest, most profitable industry in the history of capitalism. And our fight is a fight to dislodge the stranglehold of those profiteers over the healthcare, the future of healthcare in this country. This is a fight against concentrated economic and political power. And that leads us to our third principle, which is that labor must be at the center of this fight. Number one, and most importantly, labor at its best exists to fight concentrated economic and political power. And we need to be, use all of the resources, the organizing capacity, the political connections of the institutional labor movement if we have any hope of winning this fight. And, history has shown in nearly every other country that has established healthcare as a right and a universal publicly funded system, those fights have been led by an active labor movement. The other reason that labor needs to be central in this fight is that it's really, if you look at it, it's politically impossible to pass reform this large and this transformative without the active support of the labor movement. And this is especially true in states like New York, as we have found out, where, labor is, extremely influential politically, and their active support is really required for any kind of progressive reform to make it through. So, we can't conceive of how we could win this massive reform, one of the most important things we could do to improve the security of working class Americans without having labor at the table. And that's really our broad mission, to bring labor to that table. So I was recently listening to John O'Malley, who's out of another New York union, CWA Local 1180. He was talking to the PNHP Physicians for National Health Program New York Metro chapter last month, and about this issue of why unions have not jumped in with both feet, and particularly in New York, in support of the New York Health Act. And he basically said that unions will support Medicare for all model healthcare reform when they see how unsustainable employer provided and union bargained healthcare is for their members. And that was really, the crucial moment, that if they feel that they can do a good job or a passable job bargaining, it's the world that they know, and that they feel that they can do it effectively, they're going to continue in that direction. But once they come to the conclusion that that's no longer going to produce results, that's when change is going to be really begin to occur within the labor movement. Now, I would argue that it's for the last 40 years, healthcare has been the biggest cause of strikes and lockouts and concession bargaining. I've been bargaining contracts since the early 1980s, and by the late 80s, we were lucky to emerge from contract negotiations with the same healthcare benefits that we went into those negotiations with, and that was, members anticipated that was going to be the biggest issue. And, they would quietly whisper in our ears before we went into bargaining, whatever you do, don't let them mess with our health care. If we got to take a wage freeze, don't let them mess with our health care. If we got to give up work rules, don't let them mess with our health care. And the bosses understood that when we went into bargaining, and they used healthcare as a threat that they held over us to make concessions in other areas, and they continue to do that. I would say that healthcare is one of the biggest drivers of wage stagnation for working class Americans over the past 40 years. And you just have to look at the numbers. I mean, in 2019, there's a consulting group called the Millman Associates that do something called the Millman Medical Index. And they kind of look at the costs and the payment structures of decent employment-based healthcare plans, like a PPO style healthcare plan that a lot of union folks would have. In 2019, they calculated that the total healthcare costs for a working class family of 4 were $28,000 per year. And out of those costs, the employers were paying about $15,000 towards employment-based health care. And then the worker and their families were paying $13,000 with all the other costs, co-insurance, co-pays, deductibles, out-of-pockets, all of the other ways that the medical industrial complex extracts money from us. Those numbers have gone up consistently year in and year out, and the percentage of healthcare costs paid by the worker has increased consistently year in and year out since the late 1980s. So that's a reality that we're facing. $28,000 per year is a gigantic nut to crack. That's $14 per hour worked for a full-time worker over the course of that year. That's almost twice what the federal minimum wage still is. It becomes almost insurmountable when you think about, the challenge of organizing low-wage workers, where you find, the employer viciously fights those organizing campaigns, because not only will they have to pay a living wage, but they're going to have to come up with an extra, $20,000 a year for healthcare coverage to meet the union demands. And they'll fight us tooth and nail on organizing low-wage workers. And it's a challenge even with high-wage workers, where you have non-union employers competing on healthcare costs when they bid for contracts. So in the building trades, particularly in areas like in upstate New York with lower union densities than New York City, non-union contractors can almost match the union wage structure, but then deeply undercut unions on healthcare costs and come in there and steal work for union workers and undermine, sustainable union jobs. So this is a challenge throughout the workforce, from the highest paid to the lowest paid. And then along comes the pandemic 2.5 years ago. And that really, if nothing else, drove home the folly of linking healthcare to employment. I mean, who would link healthcare to employment? It was a dumb idea when we were forced to do it in the late 1940s after the dreams of continuing the New Deal reforms were crushed. And the absurdity was really brought to bear during the pandemic. For 1 year, from March 2020, 1 million workers a week were forced into unemployment during the darkest days of the pandemic. And most of them lost their healthcare benefits or were forced to come up with exorbitant COBRA payments or forced to move on to the meager healthcare plans like Medicaid in order to continue their healthcare insurance. And union funds, union health and welfare funds, did a heroic job trying to continue coverage, but they were squeezed left and right and were forced to eventually cut coverage, and are still trying to recover from this debacle. So the pandemic should be the nail in the coffin for individual employment-based healthcare. And most unions know this, and in theory they support Medicare for all or some solution like that. And in fact, the high point of union support was reached in 2019, when for the first time since the early 1990s, national unions that represented a majority of organized workers endorsed the Medicare for All Act of 2019 that was submitted by Representative Jayapal into the Congress that year. Since that year, 2019, there has been some considerable backsliding on the national union front in terms of support for Medicare for All. And I would attribute most of that to the sort of unions that are wrestling with their instrumental political relationships, particularly, the desire to support the Biden administration because of, other priorities that they have that they need to work with the Biden administration on. And as you know, President Biden ran in the primaries as an opponent to Medicare for All and supported the effort at the 2020 Democratic Convention to not to include Medicare for All as part of the Democratic program. So, there was a fight in the Democratic Party. Medicare for All supporters lost that fight. Many unions saw that, and, whatever their personal position towards Medicare for All was, felt that it was perhaps not wise to support that when they had other political priorities to pursue. And that's something we really need to work on. And then, looking at New York and New York City, there are unique challenges in New York. And it's really kind of this paradox. I mean, New York has close to Canadian levels of union density. It's one of the most union dense states in the country. It competes with Hawaii and Alaska and Washington for the top spot. And unions are hugely influential and have a lot of power in New York. But paradoxically, this has meant that, they haven't had to face the crises that many other unions around the country have faced. And the kind of old style of business unionism has really prevailed in New York in ways that it hasn't in other places, just that where change has really been driven by crisis. And that's led to a certain amount of complacency on the part of the leadership of large unions in New York, a certain lack of vision and a certain sense that, that they're going to continue, that the current situation will continue indefinitely into the future. And, you know, I mean, I would just say you just have to look across the Hudson River at what happened in New Jersey when, Governor Christie took control of the state and basically outlawed bargaining over additional health care benefits that exceeded certain levels that were legislatively set in the state of New Jersey. The New York unions may be complacent, but they may also be one election away from facing a reckoning around healthcare issues. So we have to figure out a way to move forward on this challenge. And, the healthcare costs, while somewhat muted in New York, continue to drive bargaining. And that was really driven home last year when the Municipal Labor Council reached an agreement with the city of New York to transfer all of its retirees into a Medicare Advantage program. And most unions supported this as what they felt was a relatively painless way to save the city $600 million and thus protect jobs, wages, and benefits in other areas in the municipal contracts. Now, PSC, to its everlasting credit, really dug into this proposal, took a hard look at it, and exposed how this was really a bad deal for retirees. And because of the great work that the union did, and I'm not intimate with the work that you all have done as a retirees group, but I would imagine that you had something to do with pushing PSC to make sure that they did this work. There is at least a temporary stop on the implementation of this Medicare Advantage plan, or the imposition of Medicare Advantage on the retirees. But as you probably have surmised, this fight is not over. The city continues to insist that they want to move the retirees into this program. A number of other unions in the city seem to continue to support that. And this fight's going to continue until Medicare for All provides healthcare security for everybody in America, or New York Health provides that kind of security for New Yorkers. Until everybody is secure in their healthcare, no one's healthcare is secure. And that, we really need to think about that. We need to move beyond the narrow perspectives of our own members and think about what, will be best for all working class Americans. By doing that, we do the best that we can for our members. So what can you do in PSC CUNY and as a retiree caucus to continue in this fight, to continue to move forward? Well, first and foremost, I think you got to continue to be in the lead on this Medicare Advantage issue within PSC CUNY, and to reach out to the other unions and other union members in New York City around this issue, because this is the tip of the spear in terms of thinking about whether we're going to continue to bargain for our health care or whether we're going to turn health care into a public good. I think that also means helping move your parent union, the American Federation of Teachers, into a more active engagement on these issues. Right behind Medicare Advantage, there is an ongoing program that was started by the Trump administration and is continuing under the Biden administration, called Direct Contracting Entities. It's now been renamed the ACO Reach program. And this basically allows medical groups to contract with Medicare and provide Medicare Advantage style financing models to your healthcare providers without even the knowledge of an agreement of the people who are signed up for that coverage. This is an insidious program that could deeply privatize Medicare. It needs to be stopped. It can be stopped. This is not, we don't require congressional action to stop this. The Biden administration could stop this program. And we need unions like the AFT, who are hugely influential in the Biden administration, to speak up on this issue. And, you should see how this is linked to your fight in New York against imposition of Medicare Advantage, and really work with the AFT. And likewise, the AFT nationally, if they rose their voice again in support of Medicare for All, it could make a major difference in the labor movement. It's a hugely influential union within the AFL-CIO. And your president, Randy Weingarten, in 2019 spoke in support of the Medicare for All bill, and in fact gave one of the best short union speeches in support of Medicare for All that I've ever heard from a union leader. So she clearly understands the issue. She just needs to be pushed a little bit from below to make that happen. The other thing you could do is to help other unions overcome the two chief objections that I hear from those unions about why they're not supporting Medicare for All. Number one, they tell me the members aren't ready. They don't want it. They don't support it. They're not ready to hear about it. So you got to tell them that you're ready, and you got to, find ways to convince them. One idea that we're playing around with is maybe getting local union leaders to survey their own members about healthcare conditions, and how they feel about healthcare and the future of healthcare. I think that they'll find that their members are a whole lot more ready to consider something that makes healthcare a right that's not contingent on employment than they think. Workers know how precarious their healthcare coverage is, and they know how much they have to sacrifice to continue it. And they all have family members and neighbors and friends and acquaintances who don't have the ability to access union healthcare benefits, and they see how much they suffer because of that. So we got to help our leadership understand that the members are ready on this issue. And then the second thing is to find some answers to the "we will use our union advantage" complaint. The concern that a lot of unions have is that healthcare is such a fundamental part of what unions do for their members, that if unions are no longer fighting for healthcare, or in many cases providing union-sponsored healthcare benefits, that they won't be seen as a vital part of their members' world, and that people will stop paying dues. This is particularly significant since the Janus decision took place, and as you know, public employees are no longer required to contribute to the cost of their representation, even though unions are still legally required to represent everybody. And it's a untenable position for unions to have to contemplate how you can represent people without any resources. So this is a huge consideration that unions have. And we need to look beyond the normal and think about what we could do with those benefits if we didn't have to put all the money into basic healthcare coverage. Well, how would a healthcare fund or a welfare fund provide decent benefits if they didn't have to provide medical benefits? When I ran for union president in 1983, I promised that we'd try to move our welfare fund into providing legal coverage for our members. And we were never able to afford that benefit because every nickel we bargained for had to go into healthcare. So we could think about real union advantage benefits like legal services and childcare and elder care and transportation reimbursements and education and disability and dozens of other things that our members would be proud to have as a union member. So we have to help move them beyond that issue. So we also have to think about connecting Medicare for All to broader concerns and broader constituencies and bringing in new allies. And this would require us to really take on the issues of racial equity as it applies to healthcare, to more broadly address the social determinants of healthcare, where you live, where you work, all of the factors that leads to poor health, and can bring in new supporters for a real comprehensive healthcare solution. And it also means that we have to address head on the concerns that workers who may lose their jobs because of this transition to a Medicare for all style system, those workers who work in doctors' offices, healthcare providers, and insurance companies, whose job it is to push papers back and forth. Every doctor has at least one person whose job it is to argue with insurance companies, and every insurance company has someone whose job it is to argue with that person. And those jobs are going to go away under a rational healthcare system. But the people who are in those jobs shouldn't be the ones who bear the burden for that transition. We've got to make a commitment upfront that we will provide a just and equitable transition for anyone who, through no fault of their own, is affected by this transition. And if we don't do that, I can guarantee you that our opponents will use those workers as shock troops in the fight against Medicare for all and the fight against healthcare justice. We've seen what's happened in the environmental movement, with coal miners and other workers, when their interests and concerns are neglected, when they no longer believe that we will be there for them in a transition, they're going to turn to sort of ugly and desperate solutions that aren't in the public interest. So we as unionists have got to take those issues on. So I think I better shut up now and see if there's any questions. And
Yeah, thank you, Mark. Before we go to questions from Mark, we're going to hear also from our own Len Rodberg. Len is Professor Emeritus from Queens College, where he was the chair of the Urban Studies Department for 22 years and a consultant on the very New York Health Act that Dick Godfrey described for us. So take it away, Len, and then we'll, after that, be asking you to raise your Zoom hands for questions for either speaker. Thank you.
Okay, thank you. I'm glad to be presenting and just heard two wonderful talks from Dick Godfrey and Mark Dudzik. Can everyone see my screen? I'm like all members of PNHP, Physicians for National Health Program, that I've been active in for 30 years. We use slides and I'm going to use them today, so I hope you can see them. Since I'm going to be talking about the role of the private sector in Medicare and in health insurance in general, let me make one comment about the issue that both Dick and Mark talked about, and Dick was too politic to be able to say it, but structurally, one of the impacts of our dependence on private employer-based insurance is that the unions have in effect become part of that medical industrial complex that Mark was talking about. We even have presidents of unions, including a public sector union in New York City, on the boards of directors of health insurance companies. I mean, as Mark implied at the end, they see their survival as linked to the provision of healthcare services, healthcare benefits to their members. And it's that structural defect. It's much more serious than a defect. It's catastrophic, that leads them to come to oppose the kind of progressive legislation that would in fact solve the problems of the American healthcare system. So let me get specifically to the Medicare situation. What I'm going to present is a short Reader's Digest version of a longer talk that I gave in the February forum of our PNHP chapter. If you'd like to see that and see the full set of slides, it's available on the website of our chapter, which is pnhpnymetro.org. So let me proceed. Let's see if I can get this going. So what do we mean by privatization? That's the topic that I'm speaking of, privatization, particularly of Medicare. And here's my definition. Privatization is when access to care in a health insurance program is controlled by a private profit-making entity, which makes money by limiting access to care. I mean, this country is alone among all countries in a whole number of ways in healthcare. It has set up the principal way of financing healthcare by giving it to a body which makes money by not providing care. And the proposal, the that we already, the system that we already have in the form of Medicare Advantage, and that we're being pushed into the direct contracting model that Mark introduced, both put private sector entities in that position of making money by denying care. So let me try to describe this. I used some children's blocks I borrowed from my grandson's block collection to show the healthcare system. This is the way traditional Medicare works. It uses fee-for-service, the fee-for-service model, in which your provider, your doctor, or the hospital sends a bill to Medicare. Medicare pays most of it, but Medicare is set up so that it only pays for, in terms of medical services, 80% of the bill. If you have supplemental insurance, Medigap insurance, then it sends the bill to the Medigap and they pay the rest. There may be, and there is now for those of us on the city's plan, co-pays in addition that has to come from the patient. One important point about this is if the physician or the hospital provides the service, Medicare pays it. There is no prior authorization in Medicare except in some very special circumstances involving very expensive medications. But general medical care is the doctor's prerogative. So what are the problems with Medicare? That all sounded good, but there are serious problems with Medicare. It doesn't cover our teeth, our ears, or our eyes. As you get older, they all have problems. It has costly deductibles. We have skin in the game up to of an order of 20%. We have to buy insurance, or have to something like a union provided plan, which those of us in PSC have. There's no limit on out-of-pocket expenses. All modern insurance plans do, but Medicare, of course, was devised in 1965, and there were no limits then, because Medicare medical costs were much smaller, lower than they are now. The result is the average Medicare recipient spends about $6,000 per year per person on medical care, and paying the copays, the deductibles, and on drugs, on the drug copays. So this makes it vulnerable to attacks from the private sector, and that's what we're talking about today. So the first phase of privatization actually began in the 1980s, but the most recent version of it was set in place in 2003 with what was called the Medicare Modernization Act. It added the drug coverage, but it also created Medicare Advantage, a private insurance plan paid for by Medicare. We've been discussing that a lot for the last year. But here's how it works. It puts an insurer between Medicare and a private insurer, for-profit mostly, some nonprofit, but it's hard to distinguish them. Their CEOs all make millions, whether it's for-profit or nonprofit. Anyway, it puts the insurer between the payer, which is the Medicare, federal Medicare program. CMS is the Center for Medicare and Medicaid Services, which is the agency that runs Medicare and Medicaid. Anyway, it puts the insurer between Medicare and the PCP. That stands for primary care provider, your doctor of choice, and specialists in hospitals. And the way it works is the individuals choose. They choose to move from Medicare, public Medicare, to the private insurer. And the principal reason is save money. If you're healthy, it saves you money because the Medicare Advantage has almost no premium, some no premium at all. And whereas, as I said, if you're on Medicare, you have to have some form of paying the extra 20%. So the way it works is you sign up for, or somebody signs up for the Medicare Advantage plan, and the plan notifies CMS, and CMS then sends them every month a payment to cover the cost of, it's the premium in effect, but it's a monthly capitation payment per member per month payment. So when you get sick and see a doctor, the doctor, in order to get make sure the doctors get reimbursed for their expenses or the hospital. That's to check with the insurer to get approval. This is the prior authorization system. Somebody counted 87 categories of services that require authorization by the insurer under the plan that the city was trying to impose on we retirees. Traditional Medicare, as I said, doesn't require prior authorization for medical procedures. And I have a little picture there of the article in the Times just a few days ago with a study done by the federal government showing how often insurance companies improperly refuse to cover services that are medically necessary. So if the insurer approves, the insurer pays the doctor Medicare rates or perhaps less if they've negotiated less, but there is no Medigap coverage, no Medigap insurance available under Medicare Advantage. So there's actually 25% less money available to take care of patients under Medicare Advantage plan than under Medicare with the supplement. The result is that if you get sick, you don't get treated very well, and the history and the studies all show that people who get really sick, if they can afford it and can survive until the new open enrollment period arrives, they jump back into Medicare to get the coverage they need. So the bottom line for Medicare Advantage is that it costs the government more because they provide us what today is a small, about 4% subsidy, but it's billions of dollars overall, more than government would be spending on public Medicare. It gives the patient less, as I just said, but instead of that, in spite of that, it's popular because it costs less. And so nearly half of all Medicare recipients are on Medicare Advantage today. Well, that's phase one. Phase two is now being proposed by the so-called Innovation Center within CMS. They want to provide the same private sector benefit to the rest of us who are on Medicare, on traditional Medicare. They originally called it direct contracting, or as we'll see, DCEs, direct contracting entities, namely insurance companies. And it got a bad name because of the publicity that PNHP and a lot of others gave it over the last year. So they rebranded it as ACO Reach. ACO stands for Accountable Care Organization. And their plan is by 2030 to have all of us enveloped within this plan, whether we want to or not. So what does it do? I got the same pictures here, but now it's a DCE, which can be an insurance company, and a number of them are in it as a trial. It's in as a demonstration program right now. It involves a relatively small number of people today, but still hundreds of thousands of victims of this. A venture capital firm, and we've got one in New York City that's called Pearl Health, and or a multi-specialty physician practice could be. They're basically inserted between Medicare and doctors and their patients. And the way it works here is that a primary care provider contracts with one of these DCEs to get a monthly per person payment rather than work on fee for service to get a per person payment from this DCE. The DCE reports this to the CMS and they get a capitated payment every month. They take off a slice, of course, for themselves and give the rest to the PCP. And then once a year, this is how the ACO portion of this system works. Once a year, CMS calculates how much it is spending on the patients that are being treated by this primary care provider compared to what they expected. And if there are savings, they're split between the DCE and its physicians and the government. So both make money by limiting care, because the less care, the more savings. The bottom line here is that financial incentives, the prospect of savings, of making more money, are used to limit spending on healthcare. The primary care providers act like shadow gatekeepers because they know that if they don't refer to their patients to specialists or inpatient care, Medicare will be paying less and they'll make more at the end of the year. So why are they doing this? Well, there are large structural reasons involving capitalism, which I won't go into, but I'll explain how they claim what the arguments are for doing this. And there are two myths which are being purveyed by the agents of this plan. The first is that paying for care by fee-for-service leads to wasteful care and high costs. And the second is that the private sector is more efficient than government. We actually heard that from the OLR, the Office of Labor Relations, in advocating for this Medicare Advantage plan. Well, the rest of the world use fee-for-service. This is a graph from Commonwealth Fund and the OECD. It shows countries of the world, the cost of healthcare percentage of GDP over the last 10 years. And every country but ours is stable somewhere between 8 and 10%. We're up there as an outlier. And most of them, all but two of them, use fee-for-service. The difference is that their government controls prices and our government doesn't, except in the Medicare program. The private sector, of course, private hospitals, private doctors can charge anything they want, and insurance companies usually have to pay it because they need those hospitals or those doctors in their networks. But Medicare controls costs actually far better than the private sector does. So fee-for-service is not the problem. The problem in America is that we don't regulate prices, and every other country doesn't treat healthcare as a market. We do. The other myth is that private sector is more efficient. In fact, it's more wasteful. Here's Medicare spends about 2% of its total revenue, of its total budget, on processing claims. The private insurers spend more than 15% because of profits and $1 million salaries and the advertising they do to compete with each other, and the whole private approval mechanism costs them money, of course, to have people answering the phones. The real way to control costs, you look at the rest of the world and Medicare, is to keep fee-for-service. Encourage the doctors to provide the services you need, but adopt a universal Medicare for all system, or in New York, the New York Health Act. And then you set the prices or the rates, the reimbursement rates, through negotiation between government, physician, and hospital organizations, like Medicare does and all other countries do. So public funded single payer is the answer to both controlling costs and privatization. Well, what do we do in the meantime before we get universal care? Well, PS is a resolution been proposed by our chapter and by the Social Safety Net Committee. I believe it'll come before the Delegate Assembly at its May meeting to make PSC oppose the movement towards privatization, towards forcing us into Medicare Advantage plans, and to oppose these further attempts to privatize Medicare. And then to urge our parent unions, the AFT and the NICE, to oppose it as well. And if you want to get involved, the way to do it is that there's a special website for this issue created by PNHP called protectmedicare.net. By the way, there's no space in the website name between protect and Medicare. And it will connect you to let you sign a petition. It will let you connect to the members of Congress, your members of Congress, and let you get involved in other ways as well. So I would urge you to go to protectmedicare.net and join the fight. Thank you.
Thank you, Len. Okay, for folks, again, please raise your Zoom hand so that we can recognize you. And I know that Lisa has been on the queue since the end of, before Mark finished speaking. So Lisa, your question, please.
Okay, thank you. I do have a question and a statement. It seems as if
Lisa, you're not coming in clearly, so maybe just turn your video off for a second so that we hear you better. Thank you.
All right. It seems as if the CMS is perfectly content to be co-opted by Medicare Advantage. They it seems like they're powerless, and I see the problem is HHS and whatever, and the politicians, they're just like, they don't care. And also Biden, he's a lost cause. I can't stand him. Okay, that's it.
That didn't seem much of a question for
No
either.
comment.
No,
comment.
That's
one
Get your
point
member of Congress to sign
qualification.
the letter.
But do contact your member of Congress. That's fine, Lisa. Thank you. And if either of our speakers want to comment on Lisa's comment, that's most welcome. And if not, we'll move on to John.
Okay, I put a question in the chat, which is basically how it was mainly directed to Mark. But I hear Lynn's thoughts on it also. How would you respond to this position? That the labor movement, organized labor as it actually is not up to the fight that you propose that it makes. You propose that it would be the center of the fight for Medicare. And what if one perceives that the labor movement as it actually is doesn't have the ideas, consciousness, nor the stomach to make that kind of fight, because they have been already integrated, I think Len commented along these lines, integrated into the system itself. The leadership, I'm not talking about the rank and file and the general membership. The leadership likes to be at the table rather than in the streets and organizing a strong popular movement for Medicare for all. And so then how would you address that? What then? If that's the case, what then?
I guess that's more for Mark than Lynn, but yes, go ahead, Mark.
Sure, John. I mean, that's a great question. And, my first answer is, they have to be in this fight. So we got to figure out a way to make it happen. So it's impossible to drive this kind of change without labor being with us. So we got to figure that out. And then I would say that there's always been a tension in the labor movement between the sort of the day-to-day, circle the wagons kind of unionism and a more transformative fight for the working class unionism. But I think that the capacity exists. I'm old enough to remember in New York City when municipal workers had virtually no bargaining rights and bargaining power, and when hospital workers were collecting welfare checks because they couldn't make enough working full time to escape from poverty. And I saw the huge transformations that labor made in those folks' lives in the 60s into the 70s. And the postal strike of 1970 did the same thing for postal workers. My union, the oil, chemical, and atomic workers, which is now part of the steel workers, is fortunate enough to be in a union that never kind of demobilized after the CIO merged with the AFL, and led the fight for occupational health and safety, and saw that as an issue that was addressed at corporate power, and where in the 1990s, the national leadership was pushing to build a labor-based political party in this country. So there's a capacity there in the labor movement to see the big picture and to move forward. It's often driven by crisis. And I would say that, the working class is in a major crisis right now, and some elements of the labor movement will rise to that occasion. So it's our jobs as union members to kind of push that. And I know that, the labor movement, particularly at its highest levels, is incredibly bureaucratized and is insulated from the members. But you all figured out how to raise this issue of Medicare Advantage to the Municipal Labor Council pretty effectively. And I think those are the kind of strategies that we need to think about going forward if we want to insist that the labor movement fill the role that history has made for it to lead this fight for healthcare justice.
Okay, Dave, your question.
Yes, Mark, hi. look, the last couple of years, our focus here has been on the Godfrey Rivera single payer bill. But I would be interested in finding out more about what's going on at the national legislative level in Congress, but also what the AFL-CIO nationally is doing in terms of lobbying and pushing for the Jayapal Sanders bill, for example.
Okay, well, nationally, Bernie Sanders is getting ready to introduce the latest version of Medicare for All into the Senate. That should happen in the next couple of weeks.
Good.
As far as I know, Senator Gillibrand has not yet committed to endorse this version. She was there in 2019, the last time around. She was also running for president at the time. I'm not saying there's any link there, but she was there the last time. So one thing you can do, this afternoon is call her office and say that you hope that she will, as she did in the past, co-sponsor Bernie Sanders' Medicare for All bill when it's coming into Senate. But Senator Sanders is hugely influential in this Senate. Maybe not as influential as Joe Manchin, unfortunately, but he occupies the chairmanship of a crucial committee, and he can pull together an effective presence in the Senate. The Medicare for All bill in the House, the Jayapal bill has I believe 122 co-sponsors. It's the most we've had in a long time. It's a very effective bill. Obviously, we're looking at a multi-year strategy nationally. This is not going to come out of this Congress, but we're at a point where we can begin to hold effective hearings and stuff, begin to turn these bills into real pieces of legislation. So there's a lot of movement that can take place nationally. Unfortunately, the AFL-CIO has not distinguished itself as an advocate for Medicare for All. The Medicare for All is part of the official policy of the AFL-CIO. A number of unions have fought in the last few AFL-CIO conventions to make it official policy, but they have not endorsed any of the single-payer legislation at least since 1992, when there was a huge debate in the AFL-CIO, and by one vote, one union vote difference, they voted to support the Clinton healthcare plan and abandoned their historic support for what they called national healthcare back then, but single-payer style healthcare. So we still got a lot of work to do within the institutional labor movement to get them to make this a priority. The AFL convention is coming up in June in Philadelphia, and we are hopeful that we'll continue the debate at that convention, and that the new leadership of the AFL-CIO will come together around national health care. But we got a lot of work to do yet with the AFL and some other large national unions.
Okay, thanks.
Cecilia.
Yeah, I wanted to thank the speakers for their presentations. They were absolutely stunning and quite informative. And I wanted to let Mark know that it was us, the executive committee of the retiree chapter and our social safety net committee, who discovered what was happening, the possibility of retirees being moved into Medicare Disadvantage. And we brought the union into this struggle. So the real gratitude, the thanks should be given to this retiree chapter for that work. And it seems to me that any union member who is on the board of an insurance company and is accepting a stipend for that, most insurance companies give large stipends to their board members, has a direct conflict of interest, and that needs to be attacked. And then I have a question about doctors who deny services to their patients, who participate in that, and do not give their patients the kind of service that they require. Isn't that a violation of the Hippocratic Oath? And can't they be challenged on the basis of that?
Well, Cecilia, thanks for the clarity on the role of the retirees and social Social Justice Committee. I mean, 250,000 New York City retirees owe a lot to you all. So thank you for that. I don't know. I guess doctors find ways around the Hippocratic oath when they have to. I mean, I would think that there's ethical issues involved in restricting their patients' access to the best care that they can. And I also know that, doctors routinely, spend hours of every work week fighting with healthcare insurance companies to get their patients the best care that they can. And, maybe, they get worn down by that. In fact, my primary care doctor just retired, and she said she just couldn't take it anymore. The kind of fights that she has to do, the extra hours of paperwork and the calls to the pharmaceutical companies and everything else to get her patients care. So, doctors are in a tough position, and some of them distinguish themselves better than others, I guess. And I don't know if Len, you have anything to add to Cecilia's comment about the ethical.
Yeah, just that it's clearly a gray area. A doctor can feel that they're doing okay by their patient if they refer them to the lowest cost doctor, not necessarily the best. And it's a shady, I guess that's the word that comes to mind, a shady area that they're not going to lose their license for making a choice based on economics, certainly not in the current environment, which is so money oriented.
Okay, so the cue is I'm going to go to Bruce and Mike and then back to Lisa, who has a second question. So Bruce, go ahead.
Okay, hi, thanks. I want to thank the speakers too today for a really informative update on what's going on with the healthcare in the country. I certainly am in favor of the kind of healthcare that we've been receiving. Medicare misadvantage, I like that. Disadvantage, I like that pun. Is scary in terms of what it represents for us. As I've gotten older, I found I've needed more health care. And in my own experience, given the kind of health care we have available as PSC members, it's been terrific. Whenever I need the health care that I need, I can get it. And I don't take that for granted. The reason I raise it, though, is because of the concern about Medicare for all and some possible objections to that. One is the possibility that in other countries where Medicare for all is essentially in force, in England, for example, in Great Britain and in France, there have been some comments about the nature of healthcare that's available. I've had experience with the French healthcare system. I think it's very good. I'm very impressed. But I do know that the French may at times not be able to get the healthcare that they need when they need it. And I think the same thing may be true in Great Britain. And I've heard some similar comments about healthcare in Canada. So I'm wondering if that is an inevitable part of healthcare for all, and whether our speakers can address that issue in terms of what could possibly happen, what could possibly go wrong with a Medicare for all system. That's one of the concerns I think that may concern some folks when they think about this option. Thanks.
Hey, Len, why don't you go first?
Yeah, sure. Well, healthcare will be subject to the political process rather than the directly economic process that it is now. And a universal system involves everyone, from the leaders of a country to the lowest paid worker. And it will be necessary to be vigilant and to fight for adequate funding for healthcare for every other social service. The stories that we hear from Canada and Britain are exaggerated by a conservative capitalist press, so I wouldn't take them with as necessarily an unbiased view of the system. But certainly not, because people in both countries love their universal systems, whether it's Canada's insurance system or Britain's National Health Service. Okay, that's enough. I mean, of course, everybody knows that we ration care in this country on the basis of both your income and how much money the insurance companies have to take off the top before they'll pay for your health care.
Yeah, I mean, I would just amplify what Len says. If there's a problem with rationing healthcare in those countries, the numbers aren't showing it, in terms of outcomes. The people in the US are sicker, die earlier, have worse maternal health outcomes, have higher infant mortality. All of the numbers that measure healthcare outcomes do not reflect a problem with rationing healthcare in countries that have adopted a publicly financed universal healthcare model. So, and that doesn't mean there's not problems with those systems. There are continuous problems. And, I mean, one year in the 1990s, my OCAW district council met in Niagara Falls, and we chartered buses and went up to Hamilton, Ontario, and were hosted by some healthcare unions to take a look at the Canadian healthcare system. And we had a chance to look at hospitals and clinics and talk to patients and stuff. And, the patients had some gripes about the system, but when we asked them whether they, would prefer the American system, they looked at us like we were crazy. And, that's really the question. It's like, you're all union members, right? And some of you were probably shop stewards and stuff. And, people gripe all the time about the union, right? They're not doing this, they're not doing that. But then if you ask them, well, I think we'd be better off without a contract or without the union, you'll be like, are you crazy? They'll just walk all over us. And, the same kind of dynamic happens in healthcare systems. So, I think you'd be wise to, really look at the big picture when you compare the US to other systems. And then, also look at, what people, if the problem is spending money, we're already spending close to twice as much as the rest of the world spends per capita on healthcare. So, if we want, even less restrictions on care and less rationing, we could do that and maybe just spend 30% more or 20% more and still have a much better healthcare outcome. So, I think I don't want to be dismissive because, as I said, people have legitimate complaints and we're always going to have to struggle to make things better. But I think that there's no question that those systems deliver better healthcare to more people than in the US.
Thanks.
Okay, Mike.
Oops. Question to Len. Len, you mentioned that there were larger structural, in terms of privatization, the privatization of medical care, you mentioned there were larger structural issues related to capitalism. I was intrigued by that comment. You didn't go into it there, understandably, but certainly other capitalist countries have national healthcare systems and not privatization. So is it something specific about American capitalism that is at stake here? And I would say there's something specific about American labor. I mean, we've heard comments from Mark and Richard about labor being a main obstacle here. So the question to you, Len, is there something specific about American capitalism, and what did you mean by that comment? Right?
Yeah, it's I'll pass this one on to Mark, but it's the weakness of the American labor movement and the absence of a really left party, because those two factors were crucial in getting the national systems that those countries that graph I showed have. And our unions, as well Mark described it, where they are today, they're conflicted between their role in a privatized system and the potential that they hold in their resolutions, but don't act out in politically in the political arena.
Yeah, Len, I'm not, some of you might be better historians, and I don't want to, again, simplify the picture, but, most of the expansion of healthcare systems and other social benefits took place in the rest of the industrialized world after World War II. And, it's kind of a unique history here in the US versus the rest of the world. As Western Europe was emerging from fascism, there was sort of a promise that a democratic society would provide these benefits, and unions and left parties were central in that transformation. In the US and, in post-World War II history, we experienced this in labor, we experienced a resurgence of employer attacks on labor and on progressive politics. So 1946, the Murray Dingle Wagner healthcare bill was voted down in Congress with vociferous opposition from the American Medical Association and a number of employer groups. 1947, of course, the Taft-Hartley bill passed, which restricted the ability of labor unions to represent and bargain effectively and organize new members, and was coupled with a anti-communist and race baiting attacks on the most progressive and visionary sections of the labor movement. So, we went into the second half of the 20th century really disarmed in many ways that the rest of the world wasn't, in terms of our ability to advance these kind of agendas. And, we're now reaping the consequences of that now, where, outcomes for working class Americans and the security that we have, is much less than in many other places in the world. But on the other hand, I think we're also seeing, the emerging of a real pushback to those realities, and the rise of unorganized workers, the Amazon victory in Staten Island, and many of these other things, give me some hope and optimism that we're beginning to turn these circumstances around.
Thank you. Lisa.
Okay, thank you, Mark. Thank you for the segue. Concerning Amazon, don't you find it ironic that the organized labor was nowhere to be seen? They weren't part of the independent movement. Don't you find that ironic?
Well, I think they were in the corners, there was some union support there. And, what I find exciting is, when I was coming up in labor, there were old timers around who remembered the explosion of organizing that took place during the CIO days in the 30s and 40s. And, they would tell me that, people organized themselves and then they came to us, for the final step. And, that's what really gave birth to the modern labor movement, is exactly what happened in Amazon. People coming together, and from below, putting organizing, and it needs to be coupled with, the protection of the right to aggressive protection of the right to organize by the government and by broad public support. But I'm actually heartened to see what happened in Staten Island, and I would hope that national unions would develop a plan to support and sustain that kind of organizing from below that can be so transformative.
Evie, your question.
I think that each of our speakers this afternoon have added significantly to the conversation about healthcare. Now, Dick Godfrey talked to us a little bit about the power of the municipal unions here in New York City and how they have stymied passage of the New York Health Act. And Mark, my question really is directed toward you. I thought that you made some really good points, but I do want to say that I loved Len's presentation because I think he capsuled much of what we've been talking about. If you look around, the elephant in this room is the absence of minority workers at every level. Every time I come to a meeting, there are very few people of color involved. Now, the labor movement is only 10% of workers in this country. And if we are going to win this fight, which we must, we have to bring in some new people. My question mark to you is, given the growing influence of people of color in terms of population and influence in this country, how can we, as a movement, actively involve much larger numbers of people of color? And how can we help make them feel comfortable in this struggle and move over and provide some leadership opportunities for, I should say, them or us?
Yeah, Evelyn, that's such an important question. I think we only will succeed if we bring in everybody in, nobody out, and the leadership of communities of color is central to that vision. So, thank you for asking that question. I think, one way is to move back and let people of color begin to lead our movement. Again, looking at, things like the Amazon victory there, that was, it's a multiracial campaign led by Black workers. And, it was successful. And, we need to sustain those kind of projects. And then, I think we also have to move and address the concerns that communities of color who may not be that connected to the institutional labor movements, have. I think that questions of racial inequity in healthcare, are central to the healthcare justice movement. And, anybody, I have not lived in New York City in a long time, but, I know that, you can just, move from the Bronx down to the east side of Manhattan and see huge differences in, life expectancy and healthcare outcomes and everything else. And those issues are, real and profound and need to be addressed and integrated. And, the fight against them needs to be led by those communities, and we need to be there to respond and to support those fights. I think that's how you begin to build the kind of movement that can really change things.
Okay, Jane.
Oh, hi, thank you. Thank you so much for all of these speakers. I learned so much, and it was wonderful to know that of all the work that they are doing. I was struck by, Mark, by your number one point. This isn't really a question, it's a comment about the basic, that universal health care is a basic right and a public good. And the public good part of it, that means for everybody. And I think that the society would be so much happier on the whole. Everybody would be happier if we had Medicare for all. The anxiety and stress that is caused by the paying for medical insurance and the high cost of long-term care, the changing cost of medical insurance causes ill health. So I think that having Medicare for all is going to render so much good to everyone if we can just persuade everyone to take care of everyone else, that each person has to think of everyone else in this effort, in this fight. And I thank you so much for everything you're doing. And I hope to be able to join in somehow.
I'm sorry, go ahead, Mark.
Jane, this is another way to kind of expand the reach of our movement, is to frame this, as part of a broader fight for public goods. I mean, CUNY CUNY in 1974 taught me what education would look like, higher education, if it was treated as a public good. And, that's a real fight. One of our biggest supporters is the American Postal Workers Union. And they link the fight, for the public post office with the fight for publicly supported healthcare. And they see it as a very connected fight, that the same forces that seek to privatize the postal service are the forces that want to hold our healthcare in thrall and commodify our healthcare. So I think that public good framing is so important to building the kind of movement that we need to win.
I don't see any further hands, but I have a question. It seems to me we keep saying Medicare for all, but do we really imply duplicating Medicare for all with of covering 100% of care, or will there still be a 20% that has to come from someplace else?
Yeah,
So I know it doesn't exist in the New York Health Act, but Mark, if you know what's going into the new bill, please let us know.
I'll answer that, and then Len can amplify it, as I'm sure he can. I mean, I'm sorry, I use this shorthand Medicare for all because we started using that as sort of the thing. Bernie Sanders embraced that framing, when he ran in 2016. But what we really mean is expanded and improved Medicare for all. That is to, expand it to cover all of the services, the eyes and the ears, and the long-term care and everything else that's excluded, and to eliminate all the co-pays and deductibles. So the national bill in the House does that. It covers everything without any out-of-pocket costs. The last version of the bill in the Senate had one minor provision that would allow for small drug co-pays of, I think, $10 or less to encourage the use of generic pharmaceuticals. And I don't know if that'll be included in this version, but a relatively minor copay. So the authors of the bill and the leaders of the movement are not trying to replicate the stunted Medicare system that we currently live under. They're trying to improve it, which means, in fact, that current Medicare recipients ought to be our biggest allies, because their Medicare would improve. And only about 35% of Medicare recipients are lucky enough to have the kind of supplemental coverage through their employment that PSC members have. Most people are, have to either privately purchase Medicare supplement plans, which, as you heard during the fight over the city transition, was going to cost you about $191 per month for a supplemental plan to match the one that you currently have, or they go without any insurance, which is, also drives a lot of people into Medicare Advantage plans, because it does cover a broader range of services and has fewer deductibles than traditional Medicare. So if you don't have the supplemental stuff under the current system, you're really, struggling. So we should aim for more clarity. And I think we got to find new ways to explain that.
Let me just say, what I support is evidence-based policymaking. Doctors are supposed to practice evidence-based medicine, and unfortunately, policymakers like those pushing the DCEs, the direct contracting, don't follow the evidence. The evidence is that copays and deductibles keep people from getting the care they need and do nothing to contain costs. What they do in America is shift costs from private insurance companies to the patients themselves. The best example is Canada, which has no copays and no deductibles and spends, 60% of what we spend, and people get the care they need.
Thank you. I don't see any further questions. So again, hip hip hooray for our speakers, and of course our members, because they were thoroughly engaged with the presentations that you guys have given us. And I guess I'll turn it back to Bill. We might have announcements or other things for the rest of the chapter meeting. So again, thank you very much, Len. Thank you very much, Mark.
Yes.
Thank you.
Hip, hip, hooray. Yes. Let me add my hip, hip, hoorays for Dick, for Len, for Mark, and for Eileen for helping us, navigate this last hour and a half. I mean, the irony is that over the last year, I think most of us, at least I'll speak for myself, have learned more about healthcare and the problems with healthcare in this country than we ever wanted to know. We've learned more because we've been in the middle of our own crisis. As the city and the MLC attempts to move us from traditional Medicare to a privatized Medicare Advantage program. Today, I certainly opened my eyes. I learned a lot. I can't tell you how much I appreciate, what the three speakers contributed today, what people contributed with their questions. I thought the discussion was really enlightening. I put a couple of things into the chat. One, I put a link to the PSC's 2020 statement on the status of US healthcare, which includes our support for the New York Health Act. I think as John Hyland and others pointed out in the chat, it is correct that we are on record supporting the New York Health Act as a work in progress, meaning that there were certain issues, legitimate issues that were brought up by organized labor that we thought that the Municipal Labor Coalition and Godfrey and Rivera had an obligation to sit down and talk about. Well, there was willingness certainly on the side of Gottlieb. There was willingness certainly on the side of Rivera. There was willingness certainly on the part of supporters of the New York Health Act, and a total lack of willingness, it seems, on the part of the Municipal Labor Coalition to deal with those issues. I mean, the PSC called for a conquering spirit. These are all issues, as Dick Godfrey pointed out, that could be resolved, and could be resolved in a way that would put us in a much better position than we are right now, where we're trying to stop, the move to privatized Medicare Advantage. I also put in the chat a link to the resolution of the Retirees Chapters Executive Committee that Len talked about. A resolution that will go before the PSC Delegate Assembly in May. I expect the resolution to be supported overwhelmingly, if not unanimously. There's also a call, this is a resolution opposing the privatization of Medicare, with specific reference to what Len brought up, these direct contracting entities now, cosmetically renamed by the Biden administration as ACOs. Our resolution before the PSC DA calls us for then to take this resolution to the American Federation of Teachers at its summer convention. There, I think the fight is going to be, unfortunately, a lot harder, because I think that there are elements within the AFT who are even going to oppose our resolution about the privatization of Medicare, but we shall see what happens. I also put a link to the New York Times article that Len talked about. That's the April 28th New York Times article on the new report that came out from the Inspector General's office at Health and Human Services, noting that Medicare Advantage systematically has denied people care and treatments that they need. Despite this, we see that the Adams administration, I'm talking about Mayor Adams, is still dead set in pushing the Medicare Advantage Plus program. There was an article the following day on April 29th in the New York Daily News, also on the HHS Inspector General's report. But what was interesting about the Daily News piece is that it also talked about this report in the context of what's happening to municipal retirees. And the Daily News reporter asked for a statement from the Adams administration. And the Daily News article wrote, despite the HHS study, Adams spokesman Jonah Alton said late Thursday that the administration, quote, continues to believe that the Medicare Advantage plan is in the best interest of retirees and the city. That's where we stand with the Adams administration. In terms of updates on where we are, the most important update is, what happened on March 3rd when Judge Lyle E. Frank ruled that while the Medicare Advantage Plus program could go ahead, the city could not charge a premium for New York City senior care. The city has appealed that. The city tried to expedite the appeal and called for the court to hear the appeal in the June session. That's the session ending in June. They wanted it to be heard as early as last month. The appellate division turned that back down. It'll be heard in September. That's the session beginning in September, and probably won't be heard for several months, until several months thereafter. So it's going to be a while before anything happens. So the news right now is that everything is on hold. The majority of us get our supplemental insurance from New York City Senior Care. We are not paying premiums. And if Judge Frank's decision is upheld, that will continue to be the case. In a moment, I'm going to put a link to the New York City Organization for Public Service Retirees. They're the ones who initiated the lawsuit. They raised hundreds of thousands of dollars. They need to raise more because, as we know, the city is appealing the lawsuit. So before we finish today, I will put a link to where you can make a contribution. They need money. And I think it's really incumbent on as many of us who are willing to make additional contributions. I've contributed 2 or 3 times already. I'm going to contribute a 4th time after this meeting. And as I said, I will put that link in the chat. Today, we're not going to have people here from the Welfare Fund, Debbie Bell, Dean Hubbard, and others, because as I said, essentially, there's nothing really new to report. I just want to emphasize something that was raised at the last meeting, and that is that people should keep records if you're in New York Senior Care in terms of what your deductions have been, what deductions you've been charged, what co-pays you've been charged. As we know, unfortunately now, under New York Senior Care, they are charging co-pays for all sorts of things, and that certainly adds up. And it's something that I think now and in the future, we have to try to change. I'm also gonna, actually, let me do it right now. Put a link in the chat for lobbying in Albany for the Coalition for Affordable Hospitals. A coalition initiated by one of the largest unions in the city, 32BJ, coalition that the PSC has joined. And if you go to that link, it'll explain what the coalition is doing, going up to Albany to lobby for legislation that'll help reduce hospital costs. I think all of us, or at least many of us at this meeting, want to see the day when we have single payer. But we also have to pay attention to some step-by-step reforms. And this is an important coalition. And if people can join their lobbying effort on May 10th, and as I say, if you go to that link, you'll see the information. If you go to that link, you'll see the information. There are free buses. They're even going to feed you on the buses and up in Albany, to Albany on May 10th. And then finally, Samantha, well, not finally, let me just say that all of you have seen, I think, the email blast that we've done promoting the next retiree chapter event, which is going to be on June 6th, commemorating the 50th anniversary of the PSC. We've got an exciting program lined up. Barbara Bowen and James Davis will be speakers. Leila Milani, who was the key person in terms of a sex discrimination suit that was filed against the City University in the 1980s, will also speak. We're going to bring in people from who benefited from the PSC winning parental leave, something that most other unions don't have. This was somewhat 15 years ago. We're going to have a PowerPoint presentation that will provide photos from the last 50 years of the PSC. Some of you are going to be in those photos. And we're also going to have an honor roll of people who are 50-year members. About 50, maybe 60 people have notified us that they have been members of the PSC since 1972. There may be more of you. Add your name to the chat if that's the case, or email us at retirees@pscmail.org. And then finally, Samantha, if you can put up the page that lists the PSC's retiree chapter officers, past or present and future, I'd appreciate that.
Also, Jim has his hand up, so I think when we come back.
All right, Jim, when we come back. So, hold on one second. So scroll to the top and it lists the officers for the present retirees chapter EC. There's been an election. The votes are being counted today. I don't know if they've been counted yet, but it's an uncontested election. So I think we know the results. I just want to thank
This is Lisa.
the retirees EC that I've worked with the last 3 years, many of whom are going to continue on. And I want to congratulate new leadership of the retirees chapter. The new leadership will be taking office mid-May. I mean, there's a process where the elections committee has to certify the election, and then 10 days after that, the new leadership takes office. You'll notice there's a lot of continuity there, some very new faces, and I want to point particularly and congratulate Ann Friedman, who is going to be the new chair. Diane Mena, who's going to be the vice chair, and Bonnie Nelson, from the who's going to be the secretary. And these three women are going to be a powerful force in the leadership of the chapter over the next 3 years. We will continue the healthcare struggles. There's going to be a lot of new, exciting stuff. And again, congratulations to the new leadership. And let me just, you can take that down, Samantha. And Jim Perosine had his hand up. And then before we leave, let me get that link to you for the New York City Organization for Public Service Retirees, and I will put it in the chat. Jim?
Yeah, Bill, in commenting on today's presentation, said that
as retirees, although we didn't perhaps intend it, we've become extraordinarily knowledgeable and expert about this healthcare crisis that we're in the middle of. Unfortunately, it's not the case that the rest of the PSC membership shares our knowledge and expertise on this issue. And that's why the retiree chapter and the Social Safety Net Working Group have put together a series of pre-DA presentations on the Thursdays when the DA meets. And the third of this series will be coming up on May 19th. And I bring this up to urge you to register for it. It's going to be a presentation by Len Rodberg on the issues that he's considered today in an expanded version. But I'm bringing it up now with you because while you may have knowledge and expertise, your networks don't necessarily share it. And I would like you to spread the word about the May 19th event. Information for registration will be posted on the website and in This Week in the PSC and so on very shortly. But be on the lookout for it. We want you to register. We want everybody you know to register for this event. So thanks.
Yeah, the information is also going to be on an email blast that will probably come out the end of this week. Probably be my last email blast to you. We'll have information there about our new officers, and we'll certainly provide the link to this pre-DA session. And let me recognize Ann Friedman, who's starting on June 6th, is going to be chairing these meetings.
Yes. Hi, everybody. Well, Bill is presuming that he doesn't get more write-in votes than I will get votes once they count the ballots. I have much to say to you, but the most important thing to say today, and this won't be the first time we talk about Bill, we will have many other opportunities to celebrate him, to thank him, and we can't close this meeting today without acknowledging the outstanding work that Bill Friedheim has done shepherding this chapter over the last 9 years, particularly during the pandemic, and even more so in this Medicare Advantage struggle that we've been in. I have known Bill for many, many years. We both taught at BMCC together, and he was the chapter chair there, I think, twice. In fact, Bill has a lifelong history of being a progressive activist, a union activist, and a union leader. And again, we'll hear more about that at another time. But I know people get anxious when there's change, especially when the leadership has been so outstanding. But Bill is staying on. Bill has already agreed to do this and that and this and that. And wonderful person that he is and wonderful leader that he is. And as I look across my Zoom photos, since I can't see you in person at a meeting, occasionally I Zoom across to see the pictures of, or the names of all the retirees attending our meetings. I know many of you actually in person, actually met and worked with you in person. And many of you I've just met over the last couple of years on Zoom. And this is a terrific chapter. Every meeting that we have reminds me that this is an outstanding, terrific chapter. And we will all work together to continue all the important fights that we have. And I don't know, Samantha, if you could unmute everybody and we could give Bill a absolutely tremendous round of applause. I would hope we can do that. If we can't do that, applaud with your Zoom hand or applaud with your right hands, your own hands. And thanks so much, Bill. We will have more to say to you and about you in the coming weeks. And thanks so much, Bill.
Thank you,
Bravo,
Bill.
Bill.
Thank you, Ann, and thank you all. I mean, you really know how to make an old guy like me feel good. What's made this job easier and exciting is really an incredible retiree EC that I've been working with over the past 3 years and actually over the past 9 years, and an incredible, exciting chapter. I appreciate you all. As Ann said, you'll probably be seeing more of me. I will continue to stay active, but thank you, thank you, thank you. What a pleasure. It's been a really great ride. Thank you. So with that, we'll call it a day.
One more thing. I just want to also, again, invite everybody to the Environmental Justice Working Group that's going to meet to May 3rd, which is tomorrow at 6 p.m. on Zoom. And we're going to be talking about environmental education across the curriculum. Obviously, environmental health is so closely related to our health. They go together. Okay.
Can I, one more thing, may I make an announcement? This is Martha
Yes.
Gold. In your May newsletter, Bill was kind enough to describe a play that's going to be opening at the Tank Theater on May 21st. It has 7 people who are either graduates of CUNY or professors at CUNY involved with it. I'm the playwright of the play. It's about labor and pacifism during World War II in New York City. And we would love to think that the CUNY community would come out and support the work. Ruth Milkman, who's from the Graduate Center, is going to be doing a talk back on labor in the 1940s. It seems very relevant to the conversations we've been having here today. May 26th that's going to follow the performance. There is more information in your newsletter. Take a look for it. Thank you very much.
Yeah, and the last email blast, we also gave you Martha's email address if you want to get discount tickets for the play. And we'll repeat that in the next email blast. So thank you, Martha.
Thanks,
And
Bill.
Thank you, everybody, and goodbye.
Thank you, Bill.
Bye. 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 Bye.
Bye.
Bye, everybody.